One, two, three. Okay, welcome to the spine conference. Today's discussion will be on adjacent level disease in the cervical spine. So just a reminder, I record this and put it on YouTube, so please keep all comments rated G. Just 1 second. Adjacent level. So this is a common topic now in spine where probably because of the artificial disc implants that are new sort of in the industry. They say that the companies say that, well, I shouldn't say that. I say some people say that if you place an artificial disc, you do not get adjacent segment disease. So, but we'll get into that. I'll tell you what it means. So we'll start with this case. This was an X-ray from 2004. And at the time, this woman was 51 years old, and she had had a C5, C6 anterior cervical fusion in 1990 with iliac crest at C5, C6. And she presented to the ER with neck pain and arm pain, and these are her X-rays. So you can see, Aaron, please point out, you can see at C5, C6, there's a solid fusion. You see how when you go up and down those vertebral bodies, it looks completely homogeneous. That's a solid fusion with no plate and screws. So at that time, well, actually at that time, in 1990, let me think back. In 1990, plates and screws were sort of in their infancy. I think Synthes had a plate out then, and it was not 100%. Most people did not use it, I think. For one level. They felt that there was evidence that you did not need a plate and screws for one level. At that time, the locking systems weren't as good, and there was a high incidence of the plate backing out, the screws backing out. So many people didn't use it. Let's just leave it at that. And the surgeon who did it was sort of an older surgeon who was not comfortable with plates, put it that way, in 1990. This is a long time ago. So he presented to, so Aaron, what do you show everyone what you see on this X-ray? Yeah, very large anterior ossify at the front of the C4, C5 disc space, but comment on the disc space itself. C4, C5. Yeah. Very mildly narrow, right? C6, C7. What does C6, C7 look like? Yeah, that disc is very, very flat, and also it has a S-type shape, doesn't it? It's curvilinear. See, that's not straight across. She wasn't born like that. So some discs, degenerative disc disease, do develop a sigmoid type shape like that. Don't ask me why. I have no idea. But the other time you see that is in the you see that as well in the lumbar spine, common in spondylolisthesis, where it has a S-type shape. That configuration is sort of stable. Like that won't slide usually or get worse. But it's just interesting. I don't understand it. Anything else, Aaron? So the topic here, David, is that you asked me is, so a doctor did the fusion. Now, is it because you link those two bones that the other ones now work more and are deteriorating? Is that what happened? Or is it that this person is just going to just get disease? As this person gets older, they get disease. So if you see a person at the age of 21, they have no disease at all. They're totally normal. And then when you see the patient when they're 30, one of their discs is deteriorated. You give them some ibuprofen and they get better, and you never see them again. Then they come back 15 years later and they said, I want to see you again because you took such good care of me last time. Now the same problem came back, and then I get an MRI and it shows, oh, now they have two discs. So some people just deteriorate as they get older. So the question is this adjacent segment disease from the fusion, or is just a natural progression of this disease where people, as they get older, more discs deteriorate? So that's the question, and no one, I don't think anybody knows the answer. So anyway, so this woman. No, pretty healthy, just high blood pressure. That's it. Mildly, very mildly. No traumatic injuries, no sports, nothing. Non-smoker. Smoking is another independent variable, non-smoker. So, okay, so I just want to tell you a couple other things. Is that this is a landmark study that Scott Bowden did while he was at GW in 1990. So this was a long time ago. HW was the president. That can give you some bearings. And he took this was like, and an MRI at the time was in its infancy too. Like MRIs came out. The first MRI ever on any patient was in 1977. But Alan, can you remember the first time you saw an MRI?
No, I don't.
I mean, for most people, I mean,
Yeah.
that was like in research,
Yeah.
1977. But I remember, I think it was 1987. I think, because I remember in college in 1986, I wrote a paper on nuclear medical resonance. And then when I went to medical school in 1988, they had the NMR. They called it nuclear magnetic resonance, if you remember correctly. But they changed the name because people were freaked out because they thought they were getting some kind of atomic bomb in their body. And they had it in the basement at Hopkins, and it was very new. So I think it came out like 86, something like that. So anyway, so that was 1986. So this article is 1990. So this was kind of in the beginning when MRIs came. So what this person did is so MRIs had only been out for like 4 years. So Scott Bowden took 63 asymptomatic patients. Like these patients never had neck pain or arm pain in their lives, and he's tried to get the spouses as well. So you had equal men and women. There are very different ages, 27 to 73, and then he took all these normal patients with no symptoms, did MRIs on their necks, and then sent them to 3 neuroradiologists, and they read the films. And they just like, what do normal people with no symptoms ever? What do their MRIs look like? And he also mixed it in with some abnormal studies, so the radiologists didn't, they were kind of like unbiased, sort of. And what they found is if you just look at patients, just patients, they used the cutoff of 40 years old. Um, and they looked at the abnormalities. And over 40, which since I'm older than 40, I think 40 is pretty young. So over the age of 40, many people had problems. They had foraminal stenosis, a fifth of them had foraminal stenosis, 3% had bulging discs, and 5% had a herniated disc. So the reason why he picked herniated disc, bulging disc, and foraminal stenosis is these are reasons to have surgery. So a doctor would get an MRI and say, "Oh, well, you have a herniated disc, you need surgery," and they will go ahead with the surgery. But this article says, "Wait a minute, 1 out of 20 people have herniated discs and they don't have any symptoms at all, and 1 out of 5 people have foraminal stenosis, they don't have any symptoms at all. So these may be just normal findings in people." And then the other interesting, if you look at it per level, and I'm sorry this is a really busy slide, but like the highest one is degenerative disc disease, and point to degenerative disc disease, and over to 37%. So over the age of 40, a third of people had degenerative disc disease. So this is very, very common. But the other interesting thing is under 40, 8% had degenerative disc disease. So, and these patients never had surgery. So obviously, as we grow older, as humans grow older, more abnormalities are found on the MRI scan in the cervical spine. And again, these patients are asymptomatic. But I think it gives you an idea that people get adjacent segment degeneration in the cervical spines. They never had surgery. So it's kind of like a natural progression of just as we get older, many people, you get more levels have problems. And again, these are patients completely asymptomatic. So it's interesting, I think. Okay. So now back to our patient. So that one disc at C4C5 where Aaron pointed out there's a problem, she went to the University of Maryland in '07 and had an anterior cervical fusion with a PEEK device. I'll tell you what that is in a minute, and a plate and screws, and she did great. She had a right approach. So now this is her x-ray now. She presents to me with neck pain. She has a lot of neck pain. It's associated with her neck every time she moves it. She's had non-operative treatments. Nothing's working, and she wants something done about it. She can't live with it. But what do you see on the x-rays, Aaron? Now 3-4 is having a problem. Anterior ossified, yeah, a spur. And maybe sliding a little bit. That's a flexion view, yeah. And the oblique view on the right, do you think it's C4, C5 is fused? Looks solidly fused, doesn't it? So she so just if you go back, at C3, C4 was normal in 2004, and you can see C4, C5 had the problem. So C4, C5's had successful surgery, and now C3, C4 is symptomatic and has a problem. And so what's peak? Peak, I asked Brian last week and he didn't tell me, so I had to look it up. You did?
Polyether ether ketone. I knew that.
Oh, okay, my fault. Polyether ether ketone, peak cage. It's a colorless organic thermoplastic polymer. It's used in engineering. It's very strong, and they use it in bearings, piston parts, pumps, plate valves, cable insulation.
It was originally developed as an engine part.
It's very, very strong. And the way it works is you put the bone graft in the middle there, and it fuses together. And in my mind, the benefits of this thing is when you tamp it into the spine, it doesn't break. So you compare it to allograft or iliac crest, which is the gold standard. When you tamp it into it can't break. So that's kind of nice. The other benefit is they last forever, so you can have it on the shelf forever, so you don't have to worry about it expiring, unlike bone. But I don't think bone's inorganic. I don't see how it can expire. The negative is the surface area is less for fusion than bone graft, because in the bone graft, the whole area is good for fusion, while in here, just the inside part has a surface area for fusion. And the other negative I don't like is it throws an artifact on the CAT scan and the MRI scan. Some of them do, some of them don't. Interestingly, I'll show you in this implant, which I think is globus, it doesn't throw any artifact at all. So I was kind of impressed.
It's the markers.
Right. So you can see the markers in the back and the front there. It has a little. They have this little. They have a little marker. Aaron, can you show them little markers, little holes, there and there, so you can know we know where the graft is. So every one of these implants. So there's the markers there. It just tells you where the implant is.
Tantalum in our implant. It's a metal.
Yeah, and some of them have a huge artifact where you can't see it. Yeah, yeah. So just what's ACDF? ACDF is a surgery to the front of the neck, and then between the vertebral body's bones, you insert a bone graft to fuse it. It can be allograft, it can be iliac crest. You can use PEEK with the bone graft in the middle, or there's other metals too. And then you can put a plate and screws. The benefit of the plate and screws is it increases the fusion probability, and also it prevents the graft from spitting out anteriorly into the esophagus, so the graft can move if you don't have the plate. That's the anterior cervical fusion. Now, just as historically, it's also called the Smith-Robinson technique because Robert Robinson wrote the first article about it in 1955 at the Johns Hopkins Hospital. Before that, posterior, everything was done, most things were done posteriorly. So this was the first described anterior fusion for cervical spine, and he had excellent results. And it's kind of like the gold standard since 1955. In 1962, he had like a large study, like 62 patients. So it's kind of neat that it came from Baltimore, from Johns Hopkins. He was the chief of orthopedics in the 50s. So here's our patient again. We're back to our patient. So Aaron, what do you see here? Same patient with neck pain. The ribs show in the spine. Show the spinal cord. Yeah. 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 Pushing backwards towards the spinal cord. Yeah. What level is that? That's kind of interesting too. So show me the sigmoid disc of C6, C7. Go up a level. Yeah, that's C67. So that's C7, T1. That's T1, T2. So T1, T2 has some spondylolisthesis. Isn't that interesting? T1, T2 has ribs. So in your rib cage, you should not develop spondylolisthesis. So What is that? What does anyone think of that? What I know what's in my mind, but yeah, this person has a very bad spine, and as they're getting older, her spine is deteriorating everywhere. And for it to get spondylolisthesis at T1, T2, that's very severe. You can imagine. So she's predisposed to have a really bad spine, and that's why she's seeing me in the office because she has a problem. She's like, I look at these people like vascular paths, like patients have, their blood vessels just keep clotting off, or people have bad hearts. They keep going back to the cardiologist, now another stent. They have bad body part. So this patient has a bad spine. Okay, so anything else anybody? Right. So posteriorly, there's some hypertrophy of the ligament of flavum as well. And so I look at that too. That's good that you said that because you have to see where the problem is. So in my mind, I go wherever the problem's the worst. It makes sense. So, but here it's kind of equal. So I think it's simpler just to go anterior than posterior. But you can go posterior, fuse it, and do a laminectomy posteriorly. Yeah, that's good. That's good you said that. And it makes sense that both sides of the spine, both anterior and posterior, have problems because the disc is flattening out, it's deteriorating. So it's on either side of the spine, it's having a problem. And here's the axial cuts. Show everyone the spinal cord at C2, C3. It's got plenty of room. So it's somewhat stenotic. The spinal cord shape is somewhat deformed, more on the left, isn't it? And it should look like C4, C5. The C4, C5 is solidly fused. And see at C5, point at C5, there's an osteophyte posteriorly. See that? But it's not compressing the spinal cord. So she's stenotic at C3, C4, which we expected. And C6, C7, again, that's a sigmoid disc that has a problem. There is a spur there or a disc bulge, but it's not causing a severe problem in the spinal cord. Maybe some mild deformation though. So here's the CAT scan, and you can see that she's solidly fused from C4 to C6. It's a good solid fusion. And can you see that osteophyte at behind the body of C5, Aaron, in the spinal canal? Right there. See that? But it's solidly fused, so it should not give her a problem because it's not moving. And also that osteophyte over the years should resolve, but it hasn't actually, interestingly, because it was from 1990. So I'm sure that thing is a residual from her surgery in 1990, but it didn't totally resolve. The CAT scan shows that she's solidly fused. And interestingly, there's no artifact from this implant. So when I say that it throws artifact, I was wrong. It's not every implant throws off a lot of artifact. What's that? A little bit. Yeah, a little bit. But usually it makes a big black line. Some of them are worse than others. Here's a coronal cut that shows a solid fusion. And this is that same, remember that same disc bulge or osteophyte? It's made out of bone. So adjacent segment degeneration, this is an article from 2004 in the journal Spine. The percentage is 3% per year. So if you do a fusion, those patients 3% per year get a problem. And in 10 years, 25% of patients have significant adjacent segment degeneration. And the risk factors is if you do a fusion, the risk factors is if you have pre-existing disease, there's a high likelihood that will deteriorate. And also, if the first fusion that you fix at C5 or C5 to C7. So basically, the areas that deteriorate are from C4 to C7. Those are the areas that usually deteriorate. So those are high-risk areas. But having said this, I mean, I've been in practice for 20 years. How often do we see our patients come back with adjacent segment stenosis degeneration? Never, rarely, like one or two. So I don't believe it. Yeah, I mean, you would think I do like 100 a year. I should have over 10 years. It's 1,000 patients. I should have like 20 patients coming back if these numbers are right. I mean, are these patients going to other places? I don't know. But usually Harford County people stay in Harford County. So I don't think the numbers are so high. But having said that, if I'm suspicious that this level is degenerative and it's at the index level because of the study, I fuse it. So maybe that's why I don't get so many failures. So that's adjacent segment stenosis. So it's just normal anatomy. I'm gonna skip through this. Um, and the typical degeneration is at the disc space in the uncus. Show everybody the uncus where it compresses into the neuroforamina. And just C3, C4 should give C4 stenosis. So that's C4. She doesn't have much shoulder pain. So these are just reviews. C5 level. This is going to be quick. C5 level is motor deltoid. Sensation is in the same area, lateral arm. C6, wrist extension and some flexion of the elbow. C6, thumb, index fingers mostly. C7 level, C67 disc base, wrist flexion, triceps tendon, usually middle finger or ring finger. And C8 is intrinsics of the hand, gives you flexion of the fingers, and usually it's fifth and fourth finger on the nerve distribution. That's C17, C8. And the other thing is these patients very commonly say they have scapular pain, and cervical spine radiates to the scapula. Discs and facets radiate to the scapula. So back to our patients. So what should we do? Does anybody want to make a stab of what should be the surgery? Neck pain. This axial neck pain. So decompress it, anterior, posterior. Like, yeah, anterior. I picked anterior because anterior hurts less, so it's less morbid, and it's easier to recover from. Posterior is just more painful, and I think it's the pressure is more anterior than posterior. The pressure is from the disc, not the backside. So I think for her it's simpler, easier, just better to go anterior. And when yeah. That's true. So I ask patients, do you have any difficulty swallowing? And did you have a hard time swallowing after the previous two surgeries? If they say yes, that more evidence to go posterior. So I like to weigh, this is just how I practice. I like to weigh things in my mind, just keep an open mind. I haven't made my decision now. I'm just going to weigh everything. Just weigh everything, just add all the information, and then I make my decision. I feel that's like the fairest way to take care of patients is, just weigh everything and don't be biased when I take care of patients. So she never had a problem whatsoever. So that I thought anterior would be better for her. So these are just my notes from the surgeries. I took the old plate out. It was a Globus Providence anterior plate, first generation. And I had to use a 2.0 and 2.5 hexagonal screwdriver. These are just my notes. So if I ever have to do it again, I know. And then I fused C3, C4 with a 9mm allograft and a Medtronic plate and screw system. And I want to show you the fusion. Okay, this is the video from the surgery. And that's the peak spacer we talked about. And it's between the bones. And now I'm looking to see if it's fused. The CAT scan looked fused, so I was pretty sure that it's fused, but I wanted to spend an extra 5 minutes just to be sure and just to explore it and to be sure it's fused. And also, this is kind of how I learn about disease. Like, what does it look like when it's solidly fused, so that I know next time, if it's not fused, what it looks like. So, well, first of all, I couldn't move it at all during the surgery. But you can't really see bridging bone in these cases. So I wanted to look at the interface of the bone and the implant, so that's why I'm removing some bone right there. And then you can see it has it's serrated, the edges are serrated, and the bone is just solidly into that implant. I'll show you in a second. See right there. See how the bone is totally grown into the implant. And I tried to put my pen field in there and move it. It was absolutely no motion whatsoever. So on the right is the head, on the left. On the right is the head, on the left are the toes. Yeah, that's a chin on the right. You want to see that again? So on the right is the head, on the left is the buttocks, and then right and left is up and down. Does that make sense? And it's the disc space. It's where the implant is. And it's peak. And it has that little hole in the middle because it has an inserter mechanism that you use. So I'm just exploring it. So it's solidly fused. These things fuse very well, though. I'm really surprised how well they fuse. Peak spacers. The cervical spine just fuses naturally. There's just a big, very big blood supply to the cervical spine. All right. Any questions about that? Okay, so this is the intraoperative fluoro. And you can see the Aaron showed them the peak implant and the little tantalum markers. And that's solidly fused. And we did an ACDF above it with a plate and screws. So that's just our intraoperative confirmation. And this is post-op. You can see the X-rays much better in the department. And now she's fused from C3 to C6, solid fusion, and her alignment's perfect. And clinically, she did fantastic. Did you see her in the office? I saw her. She's extremely happy. Pain's gone. Feels a lot better. So this is a case of adjacent segment disease. So any questions? No, uh, I don't think it's relevant in her case, but um, I think it's a very good point. So um, I have a low threshold to check people, but I didn't think it would change anything I do, so I don't check it. I mean, people these cases do fine almost always. Um, but I mean, I assume the primary care physician checks calcium, vitamin D, because it's very common to be deficient in vitamin D. Very common, especially as people get older, because they're not outside that much. Like kids are outside more often than not. So people do very common to have vitamin D deficiency. So any other questions? But no, that's a third.